Hey, my name is Chris. Thank you for tuning in. Today I'm going to be talking about the LAP2 trial. This is my first GYN paper I'm super excited about, definitely not my last one. The question for this paper was that in regards to early stage uterine cancer, is laparoscopy a non-inferior approach to laparotomy? The main findings of the paper were that yes, you can do laparoscopy, it is non-inferior, you're able to get the nodes pretty much just as well as open laparotomy. The length of time for the surgery is a little bit longer, but there are no increased perioperative complications, and there's in fact actually less post-operative complications. In regards to their stay in the hospital, it's a little bit less for patients who had laparoscopy, and then when looking at their quality of life afterwards, it was actually improved compared to the laparotomy group. Let's break it down a little bit more. For the methods of this paper, this is a prospective, single-centered, randomized control trial completed at University of Oklahoma. The patients were collected between the years of 1996 and 2005. The patients were, compiled, and then if they had stage 1 to stage 2A cancer, they were randomized to either to receive laparotomy or laparoscopy in regards for their surgery. There was like a 2-to-1 ratio, so there was like 1,600 patients within the laparoscopy group and 900 within the laparotomy group, and that was a high enough number for them to determine for quality of life as well as post-operative and intraoperative complications. The primary outcomes that they were looking at in regards to those, as I mentioned earlier, was the first one was recurrence-free survival. That's the most important thing. But the other things they looked at as well were the length of time during surgery, how long did they stay in the hospital after surgery, and if there was any perioperative or post-operative complications. The first thing that we need to make sure is when we're looking at our two different populations, if they're equal. So there's two main tables. So this is their first table. And what we're showing here right now is that, their age is roughly the same, their BMI is pretty much equal, and the percentage of race is roughly the same as well. The next paper they're looking at as well kind of looks at the histology and pathology for the types of uterine cancers, so they didn't actually misconstrue. So looking at that portion of it, we see that, confined to the corpus for uterine cancer, the type 1A was roughly 1/3 in both groups, type 1B is 1/3 as well, and 1C was around 12% for both groups. And then the type of cancer as well, if we're looking at specifically the tumor typing, the endometrial adenocarcinoma, which is the most common type of cancer, was 80% and 82% respectively. And then roughly the serous, which is the more aggressive one, as well as sarcomas, also roughly around the same type as well. The other portion of this paper that's important to realize is that there's a conversion issue. So that sometimes patients who go in for laparoscopy, they might have to convert to a laparotomy. This happened roughly in 26% of the patients who went for intended laparoscopy. But the reason why roughly was around 50% or a little bit more than that was due to the fact that there was poor visualization. So there's inability to complete the procedure, so that's why they had to do open laparotomy. Only 15% of the patients who intended to go for a laparoscopy that ended up having to convert was due to actual cancer diagnosis. Going over the results of the paper. So their primary outcome that we're looking at was recurrence-free survival, and what they mentioned actually is that the pattern of recurrence and the site is going to be something that's going to be reported later on in the paper, but for initial the 2-year follow-up, there were no differences with them, and they kind of showed that through they had to come back and answer a questionnaire every 3 months or something like that. Then we go back to the surgery itself. So laparoscopy actually was 200 and something minutes, whereas laparotomy was 130. So there was roughly a 70-minute difference between the two procedures. This is something of note because it's probable because Virchow's triad, so if it's stasis, immobility, and site of injury. I mean, these patients are at high risk for developing clots, especially if they had elevated BMI. Neither groups did have a BMI greater than 30 on average, but some of the patients did, as well as they do have a cancer diagnosis. So they have a higher risk of a hypercoagulable state. So these patients, it could be a little bit risky, but there was no difference in VTE formation in these two patients, even though there was only a 70-minute difference in the two groups. When they looked at perioperative complications, there was no difference. Actually, in the laparotomy group, there was more arterial bleed, but it was actually non-significant of a finding. But in the post-operative setting, what they did find was that there were increased number of ileuses as well as arrhythmias, statistically significant in the laparotomy group compared to the laparoscopy group. So that was the two main findings. And then you go to length of stay. So after they completed the surgery and in the post-operative setting, the length of stay actually was something that was really interesting because they looked initially at greater than 2 days in the hospital. And they found that 97% of the patients in the laparotomy group had to stay at least 2 days. But in the laparoscopy group, it was only 50% or something like that. And then when they looked at like how long they actually stayed, well, they looked at, really it was roughly around 4 days if they did laparotomy. The intent to treat with laparoscopy was an average of 3 days because some of them had to convert to open. And then in the true laparoscopy group, so intent to treat and then actually receive laparoscopy, it was average of 2 days within the hospital. So there was a significant decrease in the amount of time they stayed in the hospital. And then lastly, there was an increased quality of life. They looked at this between 6 weeks as well as up to 2 years afterwards, and they showed that there was more happiness in the group who received laparoscopy over laparotomy. So that's the main findings of the paper. I hope that helped kind of nail in the LAP2 trial. I'm going to be going over the LACE trial in a little bit as well to look at the disease-free survival in regards to patients with type 1, but hopefully this helped out in regards to the reasons why GYN ONCs can use laparoscopy for approaching patients who have early stage uterine cancer. Thanks again. I'll see you soon.